In this webcast, I will be discussing therapeutic strategies for targeting MAP kinase-driven tumors. Activation of the MAP kinase pathway is a frequent event in tumors. These can occur by several mechanisms, which include overexpression through amplification or mutation of receptor tyrosine kinases that then lead to the activation of downstream signaling cascades, as well as mutations in the RAS family of GTPases, or through mutation in downstream effector kinases such as BRAF, which then lead to constitutive activation of MEK and ERK, leading to hyperactivation of several genes that regulate tumor cell survival, proliferation, and growth. Tumors addicted to the MAP kinase pathway are sensitive to its inhibition, and there are several small molecule inhibitors targeting either receptor tyrosine kinases, RAF, MEK, or ERK kinases. And in this webcast, I will be discussing the use of these inhibitors to target MAP kinase-driven cancers. The identification of selective and potent small molecule inhibitors of mutant BRAF V600E, such as vemurafenib, have revolutionized the treatment of melanoma. And phase 3 studies, like the one that I'm showing you in this slide, have shown the superiority of vemurafenib over standard of care, dacarbazine, for treating BRAF mutant melanoma patients. However, while the majority of BRAF V600E patients respond to vemurafenib, the resistance and disease progression does develop with a median of around 7 months. And the development of resistance in the majority of cases has been linked to MAP kinase pathway reactivation upon relapse. As we can see here, looking at the immunohistochemistry data from a patient sample, showing at day 1 that the phospho-ERK signal is there, and then after 15 days of treatment it goes away, but upon relapse on vemurafenib treatment, phospho-ERK levels come back. In fact, recent studies have shown that the majority of BRAF inhibitor resistance in melanoma is driven by reactivation of the MAP kinase pathway through several mechanisms. And as we can see here from the pie chart, there's also some occurrence of activation of alternative pathways such as the PI3K pathway in addition to MAP kinase pathways. So based on this, then the combination of vemurafenib or other BRAF inhibitors with downstream inhibitors of MEK, such as cobimetinib, should be beneficial for overcoming or preventing resistance to vemurafenib alone. A recent phase 1b trial of vemurafenib in combination with cobimetinib in BRAF V600E patients has looked at the ability of the combination to at the response to the combination of either BRAF inhibitor naive patients or patients that had previously been treated with vemurafenib and had progressed. And as you can see from this data, it seems that the BRAF inhibitor naive patients had a very good response rate, and the median time to progression-free survival events has not yet been reached, while vemurafenib progressors have more modest response, and the acquisition of resistance has occurred within 3 months, suggesting that there's a benefit of treating with the combination early on. Previously, several mechanisms have been shown to drive resistance of tumors to both MEK and RAF inhibitors, and one of those mechanisms is the amplification of BRAF. This has been seen both in cell lines, as it's been published previously by Jeff Engelman's group, as well as in patient samples. So upon prolonged treatment of COLO201 cells with MEK inhibitors, the acquisition of resistance to MEK inhibitors is associated with amplification of BRAF V600E, specifically in the MEK-resistant cells. And more recently, analysis of tumor samples from melanoma patients progressing on RAF plus MEK inhibitor treatment has also identified BRAF amplification in one of the tumor samples, suggesting that this mechanism can also happen in the clinic. Interestingly, the resistance to BRAF and MEK inhibitors that arises through BRAF V600E amplification can be largely overcome by treating cells with a downstream effector of MEK, ERK. So ERK inhibitors, as shown here, can essentially maintain their potency against the COLO206 MEK-resistant cell line that has amplification of BRAF V600E. This cell line is resistant to both MEK and RAF inhibitors, but retains sensitivity to ERK inhibitors. The efficacy of ERK inhibitors in these BRAF-MEK dual-resistant tumor models provides a potential strategy for targeting this type of resistance in the clinic, and this has also been shown more recently by other groups. ERK inhibitors are also effective against KRAS-amplified tumors that are resistant to MEK inhibitors, suggesting again that there are distinct mechanisms of resistance between MEK and ERK inhibitors. The clinical implications based on these data for the use of BRAF and MEK inhibitors in treating MAP kinase-driven tumors are as follows. First of all, the combination of cobimetinib with vemurafenib in melanoma has shown impressive and sustained anti-tumor effects in naive BRAF patients, which makes it currently the preferred regimen to be pursued clinically, and therefore cobimetinib is being tested in combination with vemurafenib in melanoma in a phase 3 trial. Cobimetinib is also being tested in combination with vemurafenib plus MET-MAB or onartuzumab as well in melanoma. And additional combination trials with cobimetinib are being tested in phase 1b, which include combination with other pathway inhibitors such as the PI3K pathway, as well as immunotherapy agents such as anti-PD-L1. And these latter combinations can also be pursued in KRAS mutant tumors, since cobimetinib efficacy is not limited to BRAF-V600E tumors. Another conclusion from this data is that MAP kinase-driven tumors are largely remain addicted to the MAP kinase pathway upon acquisition of resistance to targeting an individual node of the pathway. And the resistant tumors can be rescued by hitting alternative MAP kinase nodes. For example, BRAF-resistant tumors can be targeted by MEK or MEK-resistant by ERK and so forth. However, combinations of MAP kinase pathway inhibitor cocktails up front might be the most efficacious way of preventing resistance. In addition, there are also potential for combination of MAP kinase pathway inhibitor cocktails with inhibitors of other pathways, such as PI3K or immunotherapy pathways. And finally, the analysis of clinical samples will help guide in the future combinatorial therapeutic strategies once we have assembled a good set of inhibitors and agents that we can safely combine in the clinic.